allegiance. I
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Good morning and welcome to the February 19, 2024 meeting of the work session for the Shawnee County Board of County Commissioners. My name is Kevin Cook, serving as the chair. Joining me today is Commissioner Aaron Mays and Commissioner Bill Rippon. This morning's work session, our first item is emergency management with a update of the emergency management system and first responders. So Nelson, I'm going to turn it over to you.
Thank you, Commissioner. Good morning. Nelson Castile, Ambulance Compliance Officer. You should have received a report on Friday that is this presentation is based on, so I'm not going to go into every detail that's on that report. Following today's meeting, I'll have that report on the consent agenda for this Thursday, and also I'll send out the presentation and the link to this so all our stakeholders can see it. I'm going to start here. All right, in February 2023, just under 12 months ago, through your fortitude and proactiveness, you put into effect Resolution 2023-14 that is what we're talking about today. Also, on this presentation, you'll see that these are the 6 other contracts that kind of guide what it is that we do in here on an everyday basis with the ambulance and the EMS system. So that resolution you put in, it had specific task forces, work groups, committees that were formed. These are made up of stakeholders from throughout the Shawnee County EMS system. On the end of the report that you received Friday is a list of the folks that have been invited and some of them that are already members of that. Their job, and what you'll see at the end of this presentation is when we really get into the meat and potatoes of things, is that they were to assess, analyze, and take notice of some specific improvements that maybe need to be made. We found that there's a contract that was put in place pre-pandemic is not necessarily the contract that we may want post-pandemic. A lot of lessons learned came out of that, a lot of best practices. We have been reaching out to stakeholders to find out from them what it is that they would like to see, what it is we have as gaps. And in the process, we have had some successes already. First, I'll go through, you formed four permanent work groups, committees, and task forces. The EMS Communications and Technology Group, because much of EMS now involves technology, not only on the AMR side of things, but on the dispatch side, on the first responder side. A lot of technology out there that we used during the pandemic that was not available pre-pandemic, and now we're using it post-pandemic. The EMS Protocol Task Force, you'll note in your report, that one was actually formed before the resolution because we saw that we had some gaps in some protocols. We wanted to get folks together. How we do business before and during the pandemic is different for how we're doing it now, and we want to make sure that we are addressing all those protocols and making sure that what we're doing is effective and results in the best patient care possible. The EMS Stakeholder Task Force, which several county employees are on, as well as the hospitals, firefighters, a couple of the other folks in the communications center. This is the group that has come up with the most items, but these are the ones that we want to have tell us exactly what they see in the system and what they'd like to see from it. And then the First Responder Communications and Compliance Committee, this one is made up of the fire chiefs, AMR, and communications. This allows AMR on a monthly basis, it's the third Wednesday of the month that we meet, AMR to work directly with the fire chiefs in a meeting that is solely based on EMS. That way we don't interrupt their other county fire chiefs meetings or anything where they're discussing sometimes EMS, but a lot of it is fire that they want to have solved. I'll stop here. Is there any questions so far?
Questions for Nelson? No. All right.
Okay. All these committees, task forces, and groups, we didn't want them just going in with with just a white sheet of paper. So I've created some documents here. I guess you could call them maybe the Cliff's Note version of things. These are on the ambulance compliance website. This kind of lays out where the system is, where it's been, where we think it may need to go. It also answers any of the questions that they may have about why the system operates the way it does now. It also asks for input, and it also looks at the actual confusion out there about what we pay AMR to do and what we do not pay AMR to do. So in the short time these folks have met, the Communications Technology Group, it has met 15 times since middle of July. The Protocol Task Force, it's met 17 times since September of 2022. That's the one that we kind of had an ad hoc committee that we wanted to look at before we got the resolution going. The Stakeholder Task Force, it's met 12 times since July 17th. And then the First Responder Communication Compliance Committee, we've kind of held off until we had something for those folks to talk about. And they're going to start talking about some of these items that that we have presented for each of those task forces. In the meantime, I'd like to talk about a couple of successes that have come out already in the last year. We successfully implemented Crew Force and Fire Mobile, which is allows the CAD to go on a phone, a iPad, a tablet, computer. The rural departments have really undertaken rolling that out. I believe we only have 2 departments left that are not on there, and that's just a matter of getting the technology in their hands, getting them trained. The personnel that takes to do some of this technology behind the scenes, we've got to let them get caught up on other projects. The patching of the radio channels, we patch together channels now so fire and AMR can talk directly to each other on medical and rescue calls. It has really cut down on the work in the dispatch center. It's also been able to foster that relationship of cooperation and collaboration when they know what they got, when they're still en route, they can be prepared for that. AMR, Ann Antrim, who is the CES, the Clinical Education Specialist, I believe is what it stands for. They are to provide free training as a part of the contract, and they've had some really good trainings that the first responder organizations reported back to me as being excellent training, very welcome. She's going to be doing, I believe if you saw the updates about a week ago, there's 6 of them coming up here between now and I believe July that she's brought in some really good subject matter experts. You would have seen on either Wednesday, Thursday, or Friday, Shawnee County auto launch of the EMS air assets, and I'll let AMR and those folks handle any questions on that. But as a part of being all the way out in zones 3 and 4, which is on the outer regions of the county, specific determinant codes to the emergency medical dispatch, an air asset is automatically launched due to time, distance, maybe the care that they need out there. We are still in the process of making some radio template changes, but those have been well received by the first responder organizations. Just like any technology, it's not like the rotisserie chicken thing there. It's not set it and forget it. Sometimes you have to go in there and revamp that. Yeah, I'm definitely showing my age, Commissioner.
I remember it. I just thought it was funny.
The changes, we continue to make changes to the CAD-to-CAD interface. As we go along with the Crew Force and the Fire Mobile, there's things that we found that they like to have in the field. There's also a lot of stuff they don't like to have in the field. And sometimes scrolling is one of them things they want to get rid of. So that is something that we have seen the coordination really work well, but we've still got some things that we want to do. The hospital patient reporting, we got a really good relationship with both the ERs right now, and in talking to their staff and their representatives, we're working on some communications so that they can all talk to each other, plus those other folks incoming can hear what's going on there right now. Couple of last things here. The first responders would like to revamp how they dispatch. This is I'm not going to get in the weeds with this. This is more of a response thing for the first responders, but they've really taken a hold of that resource management side. Everybody, and if you've read any of my reports for the last 9 months, there is a huge scarcity of resources out there. And so they are working and adapting to come up with ways to support each other and still get their missions done. The quality assessment, quality improvement processes with Mickey Huber and Ann Antrim and the folks on the protocol working group, as well as Dr. Thompson, the Joint Medical Director, we've found some issues that have come up, and we've approached the stakeholders about how best to solve that, and they've been really receptive to helping us, giving us feedback as to what they think is possible, what they don't think is possible. It's been a very good give or take effort that goes on there. And then lastly, as a part of contract 2007-2016, AMR provides each year $10,000 to the first responder organizations for tuition assistance. We passed a resolution, I believe we're on our third iteration of the resolution that you all have helped us pass on that. And because there's 9 departments and it was $10,000, the fire chiefs agreed back in 2017 that everybody gets $1,111.11, which splits it out, and then we let AMR keep 1 penny of their $10,000 back. We've seen a lot of EMTs come out of this, a lot of advanced EMTs. There's also been a couple other classes that relate to EMS that they've been able to work on. Part of contract 71-2023 that we signed at the end of February last year that also put in nurse navigation was a third dispatcher. AMR is undergoing some staffing issues, and if you have questions about that, I'll let you ask them when they're up here in just a moment. They will be down to only 2 dispatchers 24/7 in the center, and that, of course, invokes section 4.2B, which is if the phone takes longer than 36 seconds to be answered from the 911 side of the room to the other side of the room, then they get penalized. I will just say, when they had the third dispatcher in there, I saw very few of those a month. So we're hoping that we can get the third dispatcher back in there. It helped tremendously. It was a very good idea to do, and they will have the payment prorated for each month for the February and March, and we'll see where we are at the end of March. The nurse navigation, which was put in place as a part of the same contract, we are seeing some relief. It's not as much relief yet as from what I've seen in the first couple of months I've looked at, but I am working very hard to see how much relief we've seen. I do know in some of the high-level days, like last Wednesday and Thursday, nurse navigation did help quite a bit get some of those calls that did not need the immediate response. So in April, let's see, it'd be the end of April because we started April 25th. We started April 25th. I'll come back to you in May after they have provide the audited financials. I'll do an update on the whole compliance for 2023 and then the nurse navigation and come up with that for you. Do you have any questions?
Questions for Nelson? Not yet.
Okay. So there's a lot of acronyms on there. I'm sorry, but that's how we keep track of things. This is the EMS Protocol Task Force. This is the list that they will be going through and prioritizing, figuring out what it is that they think we need to be enacting. They'll be looking at the benefits and the challenges, and also is there a monetary factor that we need to do. This is in your report, so I'm not going to go through each of them. This one is on 2 pages. This is the EMS Stakeholder Committee, which Brian Cole is in the room, and he's on that task force as well. There are 24 on there. They will be looking at the same items to figure out what it is that are a priority, what are not a priority, These all say 23 because they came up. As we come up with new ones, they will be, now that we're in 24, we will change that. There's all, and I guess I lied to you, there's only 23 on that one. This one here is the communications. The couple of those are already underway. None of them are easy. They're going to take quite a bit of lift from the first responders to get to those and to get those done. It's not an overnight thing. We've also asked them as part of the crew force application and the fire mobile applications, make sure that you're able to sustain this, whether it's through the first responder grant process or whether they pay the bill on their own for that ongoing maintenance that's on there. So you'll notice some of them are duplicated, and that is on purpose. They're duplicated because some of them go across all three groups, some of them go across two groups, some of them go across the groups that you may not realize they may have something that pertains to it, or they need subject matter expertise on it. So we want to make sure that when we're doing that, we're really vetting these and getting down there and figuring out all the benefits, the challenges. This is the form that we're using for now. We'll provide the description here. Just one sentence up there doesn't tell you everything that it's going to do. We're going to list the benefits, list the challenges, look at what are the priorities out there. Is there a start date that we think we need to do it? Is there a completion date? And then the drop dead date, kind of like the legislature, they've got deadlines. We're going to put a deadline on that like they do to say, hey, we need to act on this and get this to the commissioners or to the task force or group and look and see what that is. And we will keep you updated on each of those. Any questions on what I've covered so far?
Questions for Nelson?
Not yet.
All right. Keep going, Nelson.
Okay, this last couple slides, I think there's 3 left. So the compliance for 2023, we won't be done with until at least May 1st. AMRs are required to have their audited financials in by May 1st of each year. They get penalized, I think it's $100 a day after that. If they don't, they normally get them to me middle of April. So part of compliance is looking at that and making sure that everything looks good. We share those with now the now Director of Audit Finance, Jennifer Sauer, will get a copy of those. We have them look at that, see if there's any questions, and then we present that as the compliance at the end of the month. I will say I did not find any months that AMR was out of compliance. We were close. There was, if they're out of compliance on the response time, that means that they're below 80% and they get fined accordingly, and they get a memo that says they were out of compliance, and let's look at fixing that. With the months of November and December, we were very close, but they were able to get some folks on the street there to kind of resolve that. We did have a couple of storms, and then we of course had the cybersecurity issue that was going on at one of the hospitals, which significantly increased the wall times at Stormont Vale as well as at St. Francis. The reason I wanted to mention this, in looking at my reports, you may notice that 2023 that AMR had less volume. And, well, they did, sort of. And the reason they did was as a part of Contract 71-2023, AMR is now able each month to request an exemption if the run that they made was an interfacility transfer, what we refer to Card 33s. And what that does is if there is a doctor or nurse that has indicated that the patient needs to go a certain way, it's not a code blue or a stroke or some of these immediate things. If it's something like that, then AMR can respond. They don't have the response time that they're required to meet. If it's a RN or higher, so RN, APRN, doctor, whatever else comes above that, if the AMR dispatcher verifies that those people have examined this person then they can say, okay, do you need us to come emergency or non-emergency? What type of response? Do you want first responders? If not, then they can do what's called a Card 33. They submit those at the end of the month. I look at them, make sure that they're not using Card 33 to keep from getting a late call. There's about 300 to 400 of those a month. So those are no longer as a part of compliance. So it kind of makes it weird with what the stats look like. So this is what compliance-wise, oh, she showed me, she showed me how to do something. The top one? Oh, there we go. So when we look right here at 22 and 23, it looks like it's lower, and it is because the interfacility is not in there. When we look at the interfacility, then we see the increase. While we don't do compliance on the interfacility, it has a significant impact on the system. They can't just tell the interfacility folks we'll be there in 5 hours. You know, they've still got to figure out how to schedule those in or make those runs while at the same time doing 911. That is kind of the trade-off for them. They lose that ability, or I don't have the ability to find them for those interfacilities. Now, just because it happens at an interfacility does not mean that it is automatically a Card 33. If there's an LPN there and there has been no consultation with a doctor or an RN, then all bets are off. It gets a first responder and everything else there. That is done through our the emergency medical dispatching protocols, as well as the protocols that the field units are on there. So any questions for me before I turn it over to Operations Manager Mickey Huber and Regional Director John Antrim?
I've got a couple, but I'll let Commissioner Mays or Rippon go first. Commissioner Rippon?
So I got a real quick question. On the, you mentioned that fire and EMS are now sharing radio communications. Is that all fire or just Topeka Fire?
It's
Like
all.
if townships are all on there too, or?
That's one of them maybe questions, because we're still training some of the rural departments in their templates to get to the channel that we want them to. It's kind of buried, so they're working to get that, so they just have to click a button and go to it. Topeka Fire, 24/7, they're doing it. 3 or 4 of the rural departments are doing it. The rest of them, we're working on their radio templates to get it quicker so they don't have to search through it while they're doing patient care.
I'm always surprised it's taken that long, this long to get that kind of set up, because it does appear that there's always been sort of a duplication of services when they drive the big fire truck out and then you guys show up at the exact same time. I mean, everybody looks at it and says, wow, surely one of you should be somewhere else right now, you know? And so I think that's good. It probably prevents some of that from happening.
It does. It helps them call them off in a timely manner. It also helps if one of the most common that we hear is the word stair chair, because they'll end up in a building that doesn't have an elevator in it, so they want to put them on a chair and bring them down, or they say, hey, we'll walk them down, put them on the stretcher. It's been really good across them, and like I said, there's only 3 right now, I believe.
Okay. It's good to hear that also the nurse navigation is kind of coming along. I know
Yep.
that's been a much longer process than anyone ever anticipated, but it's good to see that it's kind of getting there.
Yeah, I guess the word would be unique. We have a unique EMS community here, so we're working with our partners to kind of help the nurses understand our community, but we are seeing some relief. Nothing that I feel safe reporting right now until I've really dived into it, but it is seeing something.
Okay, great.
Nelson, let's just for those that are watching and paying attention, does the city of Topeka contribute financially any for the funds that go to AMR?
No, sir.
Okay, so this is just Shawnee County, this is just with us that fund the AMR services?
Yes, sir.
Okay, but when we looked to see, there was some discussion recently at the City of Topeka's council meeting about concerns with AMR and whether or not they were responding or not. AMR's in compliance with the contract that we have.
Yes, sir.
Okay, so if an ambulance arrives and a fire truck is already there, and the fire truck arrived at a scene before the ambulance did, that doesn't mean that AMR is out of compliance.
No, sir. And actually, I like it when fire gets there because that's the purpose of first responders. They have stations geographically out. If you'd like to give me more money, I'm sure John would put an ambulance at each corner that he could. The first responders are a tremendous asset because when they get there, they can tell us what's going on scene. We have certified and professional folks telling us, AMR, you need this, AMR, we need that. But no, that's, and the first responders, with the joint medical director, we've really allowed them to expand and increase. They are a force multiplier when it comes to some of the patient care out there.
So the fire chief or city council making a comment that the fire arrived at a scene before AMR doesn't mean that AMR is not complying with their contract, though?
That's correct, sir.
Okay. And whether or not the city of Topeka Fire Department chooses to go to advanced life support as opposed to basic life support, that doesn't impact our contract with AMR, does it?
No, sir.
Okay. That would just be another service if they choose to take that on?
Yes, sir.
Okay. Has the city of Topeka offered to help fund any of our ambulance services?
Not to me.
Okay.
I don't know.
All right. But they do receive, the fire does receive, when there's a penalty for not responding within a time frame or something of that nature, this fire department does receive some of those funds.
The 9 fire departments throughout the county do through the first responder grant process. And I think John has a slide on that
All right.
to show you, sir.
Okay, just, those are some questions I had. That's all I have for right now.
Thank you, sir.
Thank you.
What's that HAT or HAT process? What is that?
Well, I forgot to ask Brian Ashelman to get me that. That's the one thing. HAT. It's got a lot of long words to it. It deals with resuscitation and the field pronouncements. There's certain things that they look at, I believe, hemo something, and I don't remember the other one. One of them's airway. That's the one I got. There's an airway in there. But I can find out what that is for you if you like. But I'm sorry?
I'm good.
Oh, okay. We dealt with it, I believe, at one of the protocol meetings. It's a new process that I believe comes from some of their lessons learned and stuff like that.
Any other questions? All right, thank you, Nelson.
All right, I'm gonna let John and then come up here. Oh, she was?
Oh, thank you.
Probably so.
All right, good morning, Commissioners. John Antrim, Regional Director. We're going to go back a couple years. I went back and I looked for 4 centuries worth of data, and I can't find the archives anywhere. So we'll just be talking about the last couple of years. So when Nelson talked about call volume, I just kind of wanted to show you guys this, kind of what, since 2019, what our call volume has looked like within Shawnee County. You can see that there's been a significant uptick in call volume from even 2019 You'll see that there's a pretty significant drop in 2020 to actual transports to 17,002. That's going to be important when we start talking about fine structures and penalties and stuff that we've received over the last few years. And 2023 has been the highest year we've ever had within Shawnee County at transporting 18,260 patients. So the call volume continues to rise and rise and rise, and this is why it's so important as these stakeholder groups, we continue to work together and think of innovations and ways that we can improve this system, because the answer is not to continue to throw more ambulances, more ambulances, more ambulances. There's other processes that we should look at and as we continue to move through these. So just kind of highlighting kind of our compliance over the, since 2018. You can see, you know, our high point in 2019 was about 91.64. In 2021, we dropped down to 87.58%. This is going to be important again when we start talking about fines on the next slide. 2022, we jumped up to 82.26, and then 2023, we ended up at 84.41 through the month of November. I don't think December has been completed yet. Just got it done. Okay, so that may vary just a little bit. Nelson did talk about some of our challenges towards November and December, and you know there were several things that really affected the system. Number one was the security breach at Arden University St. Francis. We really had to start putting our heads together as AMR and our stakeholders to what happens if Stormont gets overrun and we're having to start transporting patients to Manhattan or Lawrence, and the amount of time it was going to take out of our system. The other thing towards the end of the year, we were really...
I'm going to stop you right there just for a minute, if I can. Why is it significant if you need to take somebody to Lawrence that would impact AMR?
Because we're looking at a truck being out of the system for about an hour, which would result in us being late on the county contract side, which would result in compliance issues and fine monies to us.
So every time you need to make a run to Lawrence or Manhattan, that's a truck that's not in Shawnee County.
Yeah, we're going to talk about that here in a couple
Right.
slides.
Go.
So the other thing that we really struggled with at one point in time, we had seven full-time employees that were off for work comp or personal injury or maternity leave. So as you know, those jobs are federally protected under FMLA for a certain period of time, so it's very difficult to backfill those positions. And with the amount of time that it takes to train someone and get them prepared to work the streets. One of the things that Mickey was able to work with and give him a lot of credit was reaching out to a lot of local operations that we have within the state of Kansas. And we were able to pull some paramedics from our Wichita, Sedgwick County operations, as well as our Kansas City operations and our Independence, Missouri operations. So we were able to bring some people from those operations to train up that had 911 experience to help put them into our system. Which I guess is one of our benefits that we have, having the footprint we do in the state of Kansas to help keep us above par, because without that, we probably would have been having a different conversation today. So fine details, one of the things that was really highlighted by the Wichita State study was the significant fine increase from 2020 to 2022. You can see we went from 24,360 up to 44,210. Well, as I showed you earlier, we had almost an 800 transport drop, right? Transports is what takes time for us. We go to the scene, we assess the patient, we load the patient, we transport them 10 or 15 minutes. We go to the hospital, we're at the hospital for approximately 15 minutes, put the truck back together, and then we get back in service. So as our volume, transport volume decreased, so does the amount of time that those trucks, or time of task, that those trucks actually decrease. The other thing during this time period, there was a significant amount of exemptions that were given because we were in a national, state, county, and local emergency, which is an exemption from our contract. So what I kind of want to highlight here is just to see, you know, our fines, while they seem like they've gone up since 2020, we're back to post-pandemic fine amounts. Nobody likes this. We obviously want to be able to perform better, and we don't want to be expending fine monies, but there's a very good explanation as to why there was a significant increase from 2020 to 2022. However, we were not given that opportunity to talk about that. So response time penalties, one of the questions you ask is what happens with those monies? This is exactly where it happens. So you can see this wheel chart, and you kind of see how much monies each agency has actually benefited from our fine monies. These particular fine monies go back into the EMS system, first responder side, to enhance EMS performance within Shawnee County. So there's a lot of things, whether they're CPR training mannequins, AEDs, cardiac monitors. There's been all kinds of equipment that these rural fire districts as well as the city fire has been able to benefit from our fine money. As you can see, the biggest, the Topeka Fire, about 48,000 is what they received, and then Shawnee Soldier Township is right behind them at about 34,000. So all of our fine monies do go back to the first responder agencies to improve the EMS system. And that grant process opens in July, June 1st. So I know at least one of you received an email from a hospital concerned about interfacility transport. So let's just talk about that just a little bit. So this slide kind of is indicative to how we're performing when a hospital calls us and says we need to move a patient to Kansas City, we need to move them to Lawrence, we need to move them to wherever. So the lighter blue, so there's a category for Stormont, there's a category for Stormont completed, as well as KU St. Francis, and then like Topeka ER. They have become a little bit of a player within our system as far as calling and requesting transports. So you can see a majority of the time of the number of times that we've been called, we're able to fulfill their needs. If you look at Stormont, for example, in 2021, well, we'll just go to 2023. We completed 655 transports for them. We were unable to complete 206. We do have a contract with Stormont that if we're not able to fulfill that transport, then we call the Tex EMS service for them to help facilitate getting that patient moved. What we're finding more and more today is that Tex EMS is busier, so therefore they're even given extended ETAs to get these patients moved down the road. As Nelson kind of alluded to, some of our challenges with the current contract, the way it's set up today, and Commissioner Cook, you kind of led right down this road, is if Mickey or his supervisors decide that we're going to take this transport to Kansas City and we send that truck out of the system, and then the whole world in Topeka falls apart and 12 calls drop in 60 minutes, we now have an ambulance that's not here to run 911. It has become pretty common within a lot of jurisdictions around the state of Kansas that 911 systems are no longer doing transfers. Emporia Fire is a perfect example. They no longer do interfacility transfers. Finney County EMS, Seward County EMS. There are more and more agencies that are protecting their resources, and we'll talk about this why here in just a little bit, to keep the 911 system staffed to try and figure out, you know, kind of how we're going to move these patients down the road. So any questions about this slide? I know that we specifically the agency that reached out to you, we're doing 80+% of those transports for that agency that have reached out to you. It's just, it becomes very difficult for us with a 911 system to justify these patients are in a hospital, they're with a nurse, they're a doctor. Yes, they need to get moved to a higher level of care. We completely understand that. But the challenge is, does that take priority over the person that might not be breathing in their home that has no medical care? So it's a finite balance of how we do it. And I think we do a pretty decent job of balancing that within the community. So I'll stand and see if there's any questions.
So for those that are not in the medical field, when you say interfacility, can you maybe broaden that a little bit for us or educate us a little bit more? Does that mean that you are taking somebody from Stormont to St. Francis or Topeka ER to Stormont? Or does that mean that you're taking somebody from Stormont to, I don't know, KU Med or Children's Mercy in Kansas City? What's interfacility mean?
So it could be both, right? I mean, it could be we do move patients from the 2 local hospitals or actually 3 local hospitals back and forth. But specifically what causes us the heartburn, and we take care of those usually pretty easily because it's basically a normal call. Where I'm talking about, when we talk about interfacility, it's where we're going to Kansas City. It's where we're going to Madonna in Lincoln or Omaha, because we need to take a patient to a rehab facility post-stroke or cardiac arrest. You know, that's a 3 or 4 hour trip one way that truck is completely out of our system. So, but it could be both. But typically hospital to hospital would be an interfacility trip.
And how many trucks do we have out at any given time?
What's your max deployment then?
7 during the day and 4 at night. And we're gonna increase 6 to 8 during the day.
Okay. And so if you have a truck that's going, you're now down to 6 that are out during the day.
And it's not unusual for like 12 to 18 calls to drop in a period of 60 to 90 minutes.
Okay.
That's one thing about Topeka. You look at our call chart, it will be like, it's steady, 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 steady. 12, 18 calls for a period of about 30 minutes, and then it drops down to steady, steady, steady. So it makes it very hard to schedule to catch those jumps as they happen through our system.
Well, one would not anticipate you could schedule emergencies. So the VA is not listed on this. Why is that?
So the VA contract was awarded to Tex EMS. We used to hold the VA contract, but 4 years ago? 2018, when they went out for RFP, they put a small business set-aside or veteran-owned set-aside into it, and therefore Tex EMS was awarded the VA contract.
Now, when you talked about Emporia and they've gone to a different type of model, do the Emporia hospitals have to have their own transport services?
Yeah, they've contracted with Tex EMS to provide their services.
So that's something that the hospitals have at their ability. They could contract to do inter-facility transportations.
And yes, and I think that's something that's gonna come out of these stakeholder groups, is ultimately who's responsible for ensuring that there's trucks available, whether it's the county or the hospitals. And I think that's something that's gonna come out of this stakeholder group when we come back and talk, is who's ultimately responsible for ensuring that those services are available.
Okay. Commissioner Mays?
Well, you asked basically the question I was gonna ask, and that's, what's the solution to this? I mean, I totally agree, if somebody's at a hospital with a doctor and a nurse there and everything, like probably getting IVs or whatever they need, they probably are in a better situation than somebody laying in the street somewhere, whatever. But, I mean, what's the solution? Is there not like another company out there that can drive people from one hospital to another? Are the hospitals able to do that themselves at some point? I mean, it seems like there's a need, because, I mean, adding that up, it's looked like probably 1,500 calls right there. So, if you're not doing it and nobody else is doing it, like, it's just not getting done, right? Is there a way to get it done?
Yeah, so I think it's kind of like, it's the difficult part, right? Somebody's gotta fund it. Reimbursements, and we'll talk about those here in just a little bit. Whether it's the transport actually meets medical necessity to find out if an insurance is going to cover that trip. So somebody has to fund it, right? So we've had conversations with at least 2 of the hospitals about a contracted unit, to which point has not really gone anywhere. I think a lot of it's gonna weigh on heavily about what you guys decide as a county as to ultimately who's responsible for ensuring that this is done. The challenge is the Board of EMS made comments at their last meeting that there is a company out of Colorado that's allegedly gonna be putting an ambulance here in Topeka to help some of this. The challenge is when we move forward and start talking about some of our staffing challenges, it's hard enough to keep 2 ambulance services, us and techs staffed, to turn around to, now you're adding a 3rd player that's gonna be competing for a lot of the same personnel, which are limited within the state anyway. So, I think the challenge is figuring out a way that you don't affect your local system, right?
Are the requirements the same to do a transport as they are to do 911 service?
Yes. Yeah, they have to be a licensed ambulance service. They have to have currently, unless this new Senate bill passes, they'll have to have 2 certified people, one at least an EMT level, and then have medical direction, protocols, and all the requirements from the Board of EMS. Now, there is non-medical, so if someone in a wheelchair just needs taken back to the nursing home, then there are non-medical services that operate here in Topeka. Some of the challenges that we're running into those groups is they will drop them off at the front door but won't assist them into the house, which then results in a call for fire EMS to go help get that patient into their house. So,
Right.
Commissioner Vaughn, questions? Yep. All right.
all right, so this is just nurse navigation. This is from April 25th until the end of, and I'm sorry for the eye chart, until the end of 2023. So you can see that approximately 778 calls were rolled to the nurse. Of those calls, 38 of them resulted in virtual care. 163 of them resulted in self-care. 32 were referred to an alternative destination like one of the urgent cares. 26 of them were sent to the ER via Lyft or Uber. And 487 came back for BLS transport. The benefit to what comes back to us BLS transport and the fire departments, this is probably who sees the most benefit out of this section right here. Actually, from this section all the way over, those are calls that the fire departments are not responding to. So if you added up the 487 over to the 38, that would be the number of calls that the fire departments do not respond to. If it comes back to us BLS, the nurse gives us a triage, and that triage tells us that this patient needs to be seen within an hour, can be seen within 4 hours, can be seen within 12 hours, and then we schedule a unit to go pick them up and transport them to the destination. Some of these have returned as ALS, which would result in a first responder and an AMR response. But I believe a majority of those, any of them, have resulted in actual ALS intervention once we get on scene. The nurse, much like the dispatcher, has to rely on the information that they're being told by the patient. I still think that there's some community disconnect within the nurse navigation system. There are some people that have embraced it. In fact, our 911 dispatchers will get calls, and 911, police, fire, medical, I need medical. Our dispatchers will answer, and they're like, can I talk to the nurse? So I think there are some people that have bought into the system, and that some of the discussion in the stakeholder groups is maybe doing some more community outreach, that if we roll to the nurse, doesn't mean you're not getting care. It means you're gonna get more appropriate care, more fiscally responsible care, releasing the ERs from being cluttered with stuff that don't need to be there. So this number of calls that have returned to us has came down significantly. When we first started, it was over 70%. But you can see we ended the year about 62%, and I think we were at 60 when I looked in January, at the end of January. Is that correct? So hopefully we'll continue to work with our nurse navigation partners so that they learn our systems. So this is some of the nurse navigation telephone information. You can see average time to answer calls about 22. 93 calls have been abandoned. We did have some problems with our phone system when we initially kicked this thing off. That for some reason we were having some problems transferring to the nurse, and the calls were getting dropped, but we were able to correct that. So about 7.98% of calls are being abandoned. We really like that to be about 5%. That maybe is the patient hung up, or it could be maybe all of the nurses were busy, and our protocol is to allow it to ring for 60 seconds before we cancel and we just send a unit. So average time on call is about 7 minutes and 49 seconds. We did start something down here at the very bottom of this Shawnee County field. During the St. Francis IT crisis, one of the things we were able to throw together relatively quickly by working with the stakeholder group as well as the protocol community or the committee was to allow us to the first responders to activate nurse navigation from the field. So some agencies, we were able to get FirstNet phones during the emergency, and we were able to give them to the fire departments. So if they got on scene and maybe the patient skirted the EMD process, they got on scene and realized that it's really a low acuity call, that they could connect the nurse right there in the house and get treatment and care for them. So as you can see, it was kind of slow. It's a new process and not understanding when to use it, when not to use it, but hopefully that's something we're going to be able to expand on in the future to allow these agencies, rather than waiting on scene, to get the patient to a nurse so that they can leave the scene. So of the patients, nurse navigation does a follow-up call with them. They do a follow-up call to ask them a series of questions. They also do that to rate. So within Shawnee County, 4.7 stars. So if that was a business on Amazon, I would buy from them. I would feel pretty comfortable. So we're about 4.7 patient satisfaction. But what's really interesting is when they break down in these calls down here is best describe why you called 911. And number one is they perceived they had a life-threatening emergency. Number two, they didn't know how else to get health care. Number three, had no other transportation available. And this number four, this is definitely not true. If anybody's ran in our system, just because you call 911 doesn't mean you're automatically going to the emergency room. day in and day out, we transport people by ambulance to wheel them right into the waiting room and put them in the waiting room to join the mass population at the hospital. And then, you know, the final one was they had problems getting to their doctor. So this just kind of gives you an idea of the people that were rolling to the nurse. This is why they're calling 911. So that's why I think this is really important that we do some further outreach education in the community about the 911 system and as well as nurse navigation and how it can be beneficial. So any questions about nurse nav?
Questions?
You take over. Go ahead.
Good morning, Commissioners. Mickey Huber, the Operations Manager. I'm responsible for day-to-day here. This part I'm covering for Mel Burgers, who is my counterpart. She handles communication. We have 2 dispatch associates that are in the dispatch center all the time. As mentioned, we're trying to increase that to 3, and Mel just did some hiring to hopefully get that accomplished. Like us in the field, she has now had some issues with maternity leave and workers' comp issues. We should be getting one of them back soon. The 3rd dispatch associate will be in the middle of the day covering those peak hours of 10 to 10. But otherwise, we start one dispatcher at 6 and at 6 p.m. and the next one comes on at 6:30 and works that 12-hour shift. They went ahead and did 445.25 hours of training last year among their 15 employees, which is a pretty substantial amount of training that they're doing to keep everybody up on the latest protocols. Mel's had a couple people from the National Academy come out and go over things with them, so they're getting it directly from the people that design the system, all the latest updates. Everything that the Academy does is evidence-based, so pretty comfortable that they're doing what they need to be doing. As you can see, they're busy. They handled 28,231 administrative calls last year, in addition to the 24,311 911 calls. So they're getting 55,000 calls for service every year. What we can do to minimize that on our end is we're trying to keep everything off of the telephones, so that none of the field crews are bugging them unless they really need to. If it's an emergency, they'll hit them on the radio. But most of the time, we're communicating with the dispatch center via text message via our dispatch software. So that gives them the time that they need to answer all the phone calls and not worry about us. As I said, if it's something emergency, we'll get them on the radio, so it's immediate. Answering times, John mentioned that we have to have it by contract within 36 seconds. You can see there that most of the time we're within less than 10 seconds. So 96.74 is what we're hitting for less than 10 seconds to pick up a 911 emergency line. Pretty darn good. They're above the national standard, which is 90.
Now, is that AMR's pickup time from, so if it gets
So when they call into the dispatch center, it's going to the Shawnee County dispatchers, and they'll ask the police, fire, EMS, and they'll say, I need an ambulance. That's from the time that the Shawnee County dispatchers identify that it's an ambulance to the time that we pick up that phone line.
Okay. So it may be more than 10 seconds than the person called in from their home, but it's 10 seconds or a little bit outside of that to get from dispatch to you.
Correct.
All right.
So some of the things that we're having troubles with, post-COVID, things have changed, right? There's just not enough people to be in the system. And this has been something that's not just here. This is identified across the country. There's just not enough EMTs and paramedics to go around. There's not enough firefighters to go around. There's not enough law enforcement officers to go around. It's just public safety is not the draw that it used to be. And that's for a number of reasons, you know. During COVID, we were all expected to be here 24/7, 365, while a lot of the country stayed at home and did their work remotely. And there's a significant risk to what we do, and people saw that. We had numerous members of public safety contract the disease, end up succumbing to the disease. So there's a lot of things that have taken away from the draw of public safety. Okay. Here in the state of Kansas, you can see what our current numbers are. Statewide, we have 5,563 licensed EMTs, 920 AMTs, and 2,714 paramedics. Of those that could recertify last year, significant portions chose not to. So we lost that portion. And across the board, it's almost a quarter. So a quarter of the paramedics that could recertify, and we recertify every 2 years. So this year, I assume we're gonna see the same number, where we have about 200, or 25% of those choose not to recertify. We're losing people from the system faster than we can put them back into the system at this point. So Things that we're looking at too is that everything's costing us more. Medical supplies are up, medical equipment's up, vehicle repairs, vehicle maintenance, fuel, everything has gone up. But we're not getting a whole lot of change in our reimbursement rates. In fact, some agencies, Blue Cross Blue Shield being one of them, has become harder and harder for us to collect from. And looking at our reimbursements, we're getting more timely reimbursements from Medicare and Medicaid and the federal programs than we are essentially from the private insurers. So,
When you're looking at recruiting and trying to get people to, it looks like a lot of it is staffing related. What are some of the things that you guys are doing to recruit? Are you adding incentive bonuses to sign and?
we have, yes.
Yeah.
We don't have them currently at this time because, I don't want to say it, but we're getting close to being fully staffed.
Okay.
I probably just jinxed myself, but, yeah, I know.
What are their main reasons for leaving, do you know?
There's just the draw to the job isn't there. You know, we expect our people to be there all the time, long hours. It's a demanding job. It's a physically stressful job. It's a psychologically stressful job. It really is a job for the young, and the young just don't have that draw towards public safety anymore. It's just not what it was, you know? It used to be that we told you, we're gonna work you hard and we're gonna work you long, but you're gonna get a decent retirement out of it and you're not gonna have to work forever. But that's not the job anymore. People that were getting into the job field nowadays, like everybody else, they want to know that they're making a difference, but they also want to have time off. They want to utilize their time off. They want to see their friends. So it's just a generational shift, and it's just not as appealing as it used to be. Did you have a question, sir?
Can I follow up, Kevin? You said that Blue Cross is problematic in their paying. Are they disputing the bills, or are they just slow paying you?
I think there's a combination of both. I don't have an actual breakdown of why, but I think it's a combination of both.
I know that in the construction industry, when the interest rates go up, slow paying happens a lot more because you can make money by keeping that money in your bank as opposed to paying it out timely.
The one nice thing is that we were given an increase in our Medicaid last year. So Medicaid is now being paid at the same rate as Medicare within the state of Kansas at 100%. So that did help us a little. But to give you an example, that means that instead of getting about $280 on our reimbursement, we're now getting about $450. So on some calls, that doesn't cover the cost of the call. So you can see we broke down the hardships by category. Wages have increased, benefits increased, equipment's gone up, supplies, everything's on up except for our reimbursement rates. So, some of the things that we're looking at to try and augment some of these is, you know, we have some systems are all done. These are coming from the National Association of AMTs. It's not specific to Kansas, sorry. A lot of systems are still considered double medic systems where they have 2 paramedics on a truck. And that's more expensive by far. Moving that down from a dual to single.
What's that?
I thought I saw it.
Oh, no, no.
Sorry. Length and response time, we're just getting busier. We have less people to do the same amount or more, so response times are going up. We're trying to figure out how to do the alternates to low acuity calls. That's the nurse navigation stuff. Having a tiered response is another way to look at it. So there are things that we're looking at to try and mitigate some of this stuff, but not necessarily everything that we can and are doing right now. Okay. Our current staffing, I broke it down for you, so you can see what we currently have in our operations manager. There's 1 paramedic, operations manager, myself, and I have 4 field supervisors. We currently have 13 full-time paramedics and 9 part-time paramedics, 1 full-time AEMT and 9 part-time, and then 23 full-time EMTs and 9 part-time. In our training division, kind of the same breakdown. We have a CES that's a paramedic, an FTO supervisor that's a paramedic. We have 2 paramedic part-time paramedics in training, and these people are listed as part of our training division because until they're done with training, they don't want to be. We keep them in the training division so that I can't take somebody that's undertrained and unequipped and put them out in the field. But I have 2 part-time paramedics in training, 1 part-time EMT, and then 5 more part-time EMTs. What we currently need is 3 more full-time paramedics, and I have 2 EMTs that are going through school that should be done in May. June at the latest, so I'll be able to rotate them from their EMT spots. I need 2 full-time AEMTs. We're augmenting our mobile health, which is our industrial medicine. We try to keep some of the people from going into the 911 system for our businesses, right? It helps them out by keeping it non-recordable to OSHA. Have us come out there and look at the minor stuff and take care of it for them at the scene. So we're recruiting AEMTs to augment that, which will free up some of our field staff and our supervisor staff. And then we're also looking for 4 more EMTs to come on board so that we can not only augment our system by adding another truck during the day, which I mentioned earlier, but also to backfill the spots for the people that are upgrading. So you can see that we've increased salaries quite a bit in the last couple of years to try and draw. That's the biggest thing we've done. We've also partnered with the Gallup Corporation to look at all of what we're doing right and what we're doing wrong, and we're trying to tailor our responses to what our employees need them to do, so to make them feel like we're a better workforce, more responsive to them, make them feel more part of it home. And then we've sponsored people to go to paramedic school. Those 2 that are upgrading, that'll be done in May, are sponsored through us to get their paramedic education. And they're going through a school in St. Louis, and then they come back here and they'll be working locally. Okay. The early activation of the air assets, this was mentioned by Nelson earlier. This just went into effect on the 12th. So we've identified some higher acuity, immediate need calls, whether they're traumas, cardiac, strokes, those type of things, where the patients would definitely benefit by having shorter transport times. And the lag has always been by the time a unit gets to scene and realizes that they need it and then requests an air ambulance, by the time that air ambulance spools up, gets in flight, gets over here, we could be at the hospital. So we've always taken these patients by ground. With this system, as soon as it's identified through the EMD process that it could be a higher acuity call, we're automatically requesting that air ambulance. So that by the time the field crews get there, start their treatment, that helicopter is in the air and almost on the ground. And then we can immediately transport them to the air ambulance and save a third or half of the transport time. And should they need to go to a specialty center in Kansas City for whatever reason, we cut down that response time dramatically. And like I said, that started on the 12th. I think we've only had 1 activation to this point, and that turned out that the field crews got there and the information that we got from the caller through the EMD process didn't actually justify the air ambulance, so it was canceled. So, questions on that? I know I ran through it pretty quickly. But
Questions for Mickey?
Just a question. Training for EMTs and paramedics, is that done locally, or is that?
So it is done locally. We have quite a few different EMT programs. So one that we get a lot of people from is through Washburn Tech right here in town. We have partnered with Barton Community College. We host their paramedic program in our building. So they only have to go to Barton 1 day a month, and the rest of the time they're here in Topeka. But most of the JCs have programs that are both of them.
So I think to add to your, an EMT program is about 15, sorry. To add to your question, an EMT program is about a semester, so it's about 15 weeks. A paramedic program is actually a degree program. State of Kansas requires that paramedics have the ability to have a degree, an associate's degree placed upon them in order to become certified. So it could take anywhere from 2 years to 2.5 years for someone to get all their prereqs and get through paramedic school. So it's a very timely process to get someone from EMT to paramedic.
The question that has just kind of come to me is, how does Topeka and Shawnee County stack up against Manhattan or Lawrence, Riley, or Douglas County as far as call volume and responses? Do we know if we have that information to kind of look at where we're stacked up against other similar communities in the state?
Yeah, so I've had the opportunity to talk to some city council members because that was brought up in a particular meeting. I don't have that data with me here today, but I'd be more than happy to get it to you.
Sure.
And specifically, the big thing I like to compare is, our subsidy is $300,000 to operate here. These people are operating on $17 million EMS budgets. So, the benefit to Shawnee County is significant. But yeah, I can get you that information. I have that.
Okay. Other questions? All right, thank you very much.
I appreciate your time. Thank you.
All right. Brings us to number 2, public comment. Are there any members of the public that wish to speak today? Administrative communications, is there anybody here wanting to speak? Commissioner Rippon, anything? Commissioner Mays?
I'm good.
I may just note that we did have the groundbreaking for the Oakland pool last Thursday. WIBW did run a news article saying that items had been cut from the project, and after contacting the newsroom at WIBW, they did run a correction Saturday, correcting their erroneous reporting, and so correcting it for the public. And so I just want to thank WIBW for following up on that. So I don't have anything else, so we're adjourned.